the Director of Geriatric Oncology at Roger Williams Medical Center, and he's going to be speaking on geriatric oncology.
Thank you. Good morning, and thanks for being here on a Palm Sunday. My topic is going to be understanding cancer in the elderly, why a geriatric oncology program. And I think pretty much if you look at everybody in this auditorium or in this area, has somebody in the family who's elderly, who's had some, at least if they're living long enough, are going to get cancer in some form. So in a way, we are all indebted to know more about the cancer in the elderly, and that's one of the reasons that I really got interested, mainly because pretty much after coming to Rhode Island, that's the population mostly I deal with. So it's not unusual for me to see, this is one of my clinic visits, one of my clinics where I collected these patients and I said, okay, this is the commonest thing that I see. A 73-year-old with pancreatic cancer with multiple problems in the form of comorbidities, and also multiple medications and so many other problems. And the question is, what do we do with them? And how many times do we come across this problem? And so this is one of the biggest issues. 87-year-old, yes, we don't screen these patients for colon cancer, now presents with colon cancer, and she's bleeding. She's on Coumadin. The issue is, nowadays, Coumadin is going out of vogue, and we have other medications like anticoagulation drugs which have come up, like Pradaxa or other things, which we as surgeons, I'm not sure how many we understand as to when to stop, what to do, and it becomes a very complicated issue to deal with these patients. And so that is why I think it becomes more of an interdisciplinary care and learning more about these patients as to what needs to be done. And look at the next patient, who's at 80-year-old with prior history of colon cancer, renal cell cancer. In fact, I left the prostate cancer in him. And it's not unusual to see these patients with multiple other cancers, cancer survivors, actually. So having come to 80-year-old, now he's present with the liver mass, so what do I do with him? And whether the patient has not had a colonoscopy, has not had, because he's had colon cancer, but now has been lost to follow-up. And big family comes in and he says, look, I don't want anything done, but the family insists that everything needs to be done. So these are the common problems that we face. And the issue is, how do we assess these patients as to whether they are good candidates for surgery or not good candidates for surgery? Not only that, we have to look at, as surgical oncologists, I don't want to look at these patients only as a surgical candidate. I want to go beyond and look at them and say, look, are they candidates for adjuvant treatment? Are they palliative care, or are they truly, see, when you deal with multiple cancers, how do we effectively palliate, or how do we effectively cure these patients? So what needs to be done? The important point here is we've got to understand, as of 2000, there are about 35 million people who are greater than 65 years of age. By 2030, we are expecting that population to double. Essentially, 70 million people are going to be above the age of 65. So you see that even 85 and over, by 2030 or 2050, it's going to be quadrupling the number of patients who are going to be there. And essentially, I'm going to see a 90 or a 92-year-old. It's not uncommon in my clinic to see a 90 or a 92-year-old who's coming with colon cancer or with cholangiocarcinoma or something that needs to be fixed or something needs to be done. So we know that in this, or at least in this age group, the cancer is the second leading cause of death. And it's, in fact, I think WHO as of 3 weeks or 4 weeks came out and said that it's an epidemic. And it's not only here, it's all across the world. And even developing countries like India and China are facing a bigger problem as their population is getting older. And it's not going to be easy to deal with this group. And it's expensive to deal with it. The question is, a lot of questions to be answered. We stopped screening for colons at the age of 70, 75. So should we or should we not? It's a very controversial topic. And again, screening for breast cancer or screening for other things are all controversial topic as to what we should be doing. So I feel the present day 50 is 70-year-old, and they are healthy, they are living good. So what do we do? And cancer, as it says, is a disease of the aging. And for some cancers, there is an age-stage relationship. However, the 65 and older are going to be, that is, they have a predilection for 11 times more likely to get cancers. Important point to note is all geriatric patients are not created equal. Unfortunately, they don't age well. Some don't age well, some age well. And where do they belong? And is some exercise, some do take care of them. And when they come to big referral centers, a lot of them are, that is, if they're capable of taking care of themselves, is when they go to a big referral center from, say, Rhode Island to New York or some other places. But it's not the run-of-the-mill patients come here to the community centers, and that's what we face at Roger Williams. Run-of-the-mill patient who is in an institution or having not taken care of themselves. And one other issue that I really see on a regular basis is obesity. I never used to see an 80-year-old who are obese, and now I see them on a regular basis who are obese, thanks to Lipitor or other agents and coronary artery diseases being taken care of, and I think they live longer, and which is good. Again, organs age differently. So when the organ functions is, whether it's younger than average or older than average or an average person, we've got to decide. And we've got to decide, meaning we've got to decide objectively and assess objectively as to what is good. And we need to identify the functional reserve on these individuals, whether the functional reserve is to the good side or to the bad side. And that is where assessment becomes a big problem in these patients. We do not, as surgeons, do not think of these conditions. When they come in, so this is a very good study actually done by a survey, good survey done. As of 2000, they looked at cognitive impairment, falls, incontinence, low BMI, dizziness, vision impairment or hearing impairment, and they sent a survey out and for patients who were greater than 65 years of age, finding out how many patients had it. And they found that as a patient aged, number of patients with geriatric conditions, or the number of geriatric conditions in these patients increased, so which actually affects their outcome in these patients. And I'm not sure how well we educate these people that when they are visually impaired, or if they can't hear, how do they even know what informed consent is? And I'm not sure how much do they understand. Does patient have to understand to undergo treatment? I think it's good for the patients to understand what they are going to have. And I think a lot of times when I insist that the families come in, because a lot of these patients stop thinking the moment I give them a cancer diagnosis and tell them that they need surgery. And so these are big problems that we face when, especially as they get older. Another big issue is comorbidities. Big three is cardiovascular disease, cancer, and stroke. And there are a lot of other list of things that happens, and which I'm not going to go through here because of lack of time. But 4 out of 5 persons who are greater than 65 years of age have one or more chronic conditions. And as the chronic condition comes in, it is permanent. That is, if they have diabetes, there are how many patients undergo transplant, but the issue is once they get diabetes, they get diabetes. Once they become hypertensive, they are hypertensive. So these chronic conditions remain in them, and it is one of the biggest reasons for their disability, which we saw that they could have a vision impairment or a hearing impairment, cognition. All these could be a combination because of their multiple comorbidities that they face. We underestimate as surgeons as to what happens to these individuals. We really do not have time to look into it. I agree completely that we do not have time to take care of all this. But if we want better outcomes, and if we want better outcomes in these patients, if we're going to take care of them, I think we should address the issue in some form or the other. It may not be us, but we should have some team or somebody who's going to take care of these patients so that when they come for surgery, at least they're tuned up or well enough for us to do the right thing for these patients. This is a study which looked at comorbidities and what impact does it have on outcomes with patients with cancer. So they looked at multiple cancers, but if I look at if I look at lung cancer, of course, if they have stage 4 disease, their comorbidities have no effect because most of them die of lung cancer. But colon, if you look at colon with distant mets, we've done a good job. That is, patients have 50% 5-year survival when they are resectable. So, but the earlier cancers, colons which are localized, which are resectable, these patients, when they have multiple comorbidities, their outcomes rely on the comorbidities. Outcomes, overall survival, is dependent on the comorbidities that is associated with them. So there is definitely a relationship not only with the comorbidities for surgical outcomes, but in general, even for treatment outcomes. In fact, there are more and more studies which are coming out, not only looking at 30-day mortality in these patients. I just reviewed a recent paper which says that that is the 1-year mortality in elderly is almost 12.5% after colon surgery. So which is a very new thought process. The question is how functional they are and what is their mortality after 1 year. Have we done the right thing for these patients by operating, by giving adjuvant treatment, by giving radiotherapy, by giving all these combinations in an 85-year-old or a 92-year-old? In fact, having said that, at the same token, I just saw my patient who was 92-year-old who came in with a large right colon mass who got refused to get operated or not. He didn't refuse, but the surgeons refused to operate on him in Florida. And at that time, so her patient is from here and the daughter brought her here and we did a laparoscopic colectomy. It's 2 years now and the patient was like, I've gained 20 pounds, I'm so happy. So the question is, which patients do we operate and which we do not, we should not be operating? So therefore, we see that there are more older patients who are living longer, living healthier, and there is more indications for anti-cancer therapy and more patients in need of getting more therapy. So that is where now we've got to assess frailty. What is frailty and how do you define frailty? First we'll have to define frailty for us to understand and assess frailty. So Freud, who was a big person who actually defined frailty, the question is which end or which spectrum of the patient comes in. In fact, I think when the patients are on either extreme, it's very easy. That is, you decide either you're going to do surgery on them or you don't. You decide you don't do anything for them. So the question is, where do they belong? Are they in between? When they are in between, when they are borderline, when they are borderline, do you do something, some form of intervention to help them out, or you do not do anything and just leave them? And that's where, when they are borderline, is when the problem comes in. So Freud would define frailty, actually says that it's not a disease, but rather a sort of being in the middle state between being functional and non-functional, between being healthy and being sick. So somewhere along the road, that's where it is. So it's a very vague definition. So that's why it becomes more difficult. And as confusing as this slide is, it is also confusing to deal with these patients because the problem is, how do we assess these patients? There are multiple issues. And if you look at it, so many other comorbidities and so many other geriatric conditions which all kick in at the same time, and either it's undernutrition, sarcopenia, and all this, and so they remain from the stage of being healthy to being frail. A lot of them are functionally impaired and falls and fractures. And essentially, Freud's definition includes weight loss, exhaustion, weakness, slow walking speed, and low physical activity. So he essentially says that loss of 10% or more of body weight in over 1 year, or low energy level, difficulty in initiating movements, slow movements, or decreased grip strength. Unfortunately, it is, a lot of it is subjective, but that is the only way that we could identify it. And that's why he says that frailty is defined by 3 or more of these criteria. So having said that, a lot of time, how do we assess our patients? And performance status, ECOG performance status, which is essentially an eyeball test. You look at the patient, you say, look, this patient is capable of walking, not capable of walking, sitting down, or standing up, and we say that the performance status is either good or bad. But it does not give a definition of what their functional status is. So this is a study out of Italy, and in fact, most of the work is being done in Europe, and they're way ahead of the curve and looking into what needs to be done. And they found that, that there is a strong association which has emerged between performance status and CGA, which is Comprehensive Geriatric Assessment. It has been found that it's a nearly 5-fold increased probability of having a poor performance status when it's recorded in patients dependent, that is, who are dependent on activities of daily living and instrumental activities of daily living. They say that there is a direct correlation. However, when the performance status is being assessed, it does not give us the functional status of the individual. The CGA, that is a comprehensive geriatric, actually adds substantial information on the functional assessment of the elderly cancer patients. Why is it important? I think if the functional status goes down, in fact, and if the patients are not doing well because of the treatment, I think we should look at it as to very objectively as to what we are doing and if we need to intervene to figure out if we could do something better for these patients. So that is, this is coming out of the literature from the geriatric population, geriatric literature, and I think it's adopted more, again, as I said, more in the European community, and a lot of surgical, there is a multi-institutional surgical patients that is, who are in the CGA is being studied. So the CGA essentially looks into functional status, which is nothing but activities of daily living, and also instrumental activities of daily living. There's another, actually, which I did not include, is timed up and go test, which actually tells us how fast can they walk. In fact, the concept is to make them stand up from a sitting chair and make them walk 10 feet and come back. And so in these, actually, a lot of studies are coming out, which I did not include here, that timed up and go test is one of the standard tests which could be useful in identifying or predictable things which could increase or at least predict whether there is increased post-operative complications in these patients or not. Another issue is comorbidity, and cognition is a big issue, but unfortunately we do not have any way to intervene on cognition or cognitive impairments. Depression, especially in the elderly, is very, very common. And so you've got to take into account in these patients whether these patients are depressed and whether they will be capable of handling the situation or not. Polypharmacy is another big issue. And when they come in, we've got to know the right medications, whether they are in Coumadin or whether they are in the newer, as I said, newer anticoagulation drugs, which is most important for us, whether they've taken their antihypertensives. All this actually would improve their outcomes. And as I had shown on the frailty index, you can see nutrition is a big part of these patients. A lot of them are undernourished. And another issue is presence of geriatric syndromes, dementia, delirium, depression. So, and also another issue is socioeconomic factors, whether there's a good family or not. I feel the family is, there is good support in the form of caregivers. A good family is a huge asset for when we take care of these patients. If they are there, it definitely helps us in taking care of these patients easier. So if you look at the data in Roger Williams Medical Center, the red is Roger Williams and the blue is rest of the country. And if you look at our population, you can see greater than 70 years of age, we see more number of patients, and greater than 80 years of age, we see more number of patients. If you look at even within the state, again, red is Roger Williams and blue is other hospitals. And you can see that at Roger Williams, we see more patients who are greater than 70 years of age. So it's not uncommon that's the reason it's not uncommon in my clinic to see these patients. So what does the geriatric oncology program do? Essentially, we have, once the patient who comes in greater than 65 years of age in the cancer center, we identify we do geriatric assessments, and we do have an interdisciplinary team meeting to figure out if something needs to be done for these patients and interventions. The basic goal of taking care of these patients when we look at them is to see to it that there is, one, improved outcomes, but also functional decline. And there's always a controversial thing about what do we study in these patients? Do we look for overall survival? Because they might die of other causes, so overall survival may not be the right index to study. And yesterday there was so much insistence on outcome measures, quality indices, and I think this is one place where I think creating this program, we are ahead of the curve as far as Affordable Care Act or any of those things are concerned. So we want to find out how good are these patients doing. So in that regards, we've got a nurse navigator who looks at these patients, and all new patients who are greater than 65 years of age, she assesses them for geriatric assessment. The only reason that nurse navigator is doing it because it takes a long time, and we don't have the time to do this. So looks at cognitive status, functional status, mood, nutrition, polypharmacy, and comorbidities. As I said, we also do the functional status using the ADLs, the IADLs, and the timed up and go test. So all these are being done, and then interventions are being placed, and the question is, there are a lot of studies which are coming out and which do not have interventions. And once we identify these patients, they do figure out, in fact, the recent article from Colorado, there's a person by the name of Tom Robinson, who's actually published quite a bit on geriatric patients, on general surgery patients, and also in cardiovascular disease who are greater than 65 years of age. His main focus is on taking care of these individual problems and figuring out which predicts their mortality or which predicts their morbidity. In fact, a lot of it is cognition falls. If they have had history of falls within the last 6 months, one, 2, or 3 times, their mortality is very high when compared to patients who do not have this. So having said that, having intervened, having identified and done the assessment, we thought it was only prudent for us to place interventions. We are figuring out if you may ask me, what are the interventions? Each person is different, and it's getting difficult to figure out. We're trying to figure out what is the right form of interventions for each, and if we could group those interventions together. And that's one of the big things that we want to figure out, what's interventions and what is the appropriate intervention. And we also give it to the primary care, send a note to the primary care. We want the primary care involved so that they know what's done. Essentially, I'm talking about interventions. Our goal, as I said, the goal of the program is to look for functional decline and quality of life improvement. And the question is, that I feel is the most important thing for these patients. When we take care of these patients with geriatric patients with cancer, I think it's the quality of life issue which needs to be addressed more than even the longevity and as to how well they are living. I'm not going to talk about surgery. I'll move on because of the lack of time. Tumor biology. I think a lot of it is different, and I think as they get older, some cancer, certain cancers behave differently in the elderly. I think I'm not sure. I'll have to ask Dr. Gass about the breast cancers, but as far as colon cancers are concerned, I think when we looked at our colon resections, laparoscopic colon resections, it was anecdotal that I looked at these patients. This is, by the way, unpublished data. This was presented in SSO and the ASCO GI. When you looked at our data on the laparoscopic colon resections, we found that 20% of these patients are, as they get older, 20%, fewer than 20% or less than 20% of these patients have, 20% patients who have less lymph node positivity than the rest of the crowd. So when you compare it to older patients, so we looked at the SEER database and looked at the number of lymph nodes and looked at the number of positive lymph nodes. We found that in stage 1, 2, and 3 patients, the number of lymph nodes that are being examined in the older patients actually still are not good enough. They still have the number of patients who get their greater than 12 lymph nodes examined is still less. And when they have 12 lymph nodes examined, we find that these patients have statistically significant less positive lymph nodes. Why, I do not know, but it's definitely there. And when they have 12 lymph nodes examined, we also find that the overall survival in these patients are better than patients who do not have who have less than 12 lymph nodes examined. So excess mortality in these patients are also, compared to the patients who have less than 12 lymph nodes examined, their hazard ratios, you can see that it does go down as the age increases. So this is one of the findings that we've had, and so it's not like similar to this. I think we are going to find more and more different tumor biology as patients get older. So when we look at clinical trials, unfortunately, there is nothing on clinical trials in the elderly. They are primarily, if you look at who are the patients who get clinical trials done, primarily middle-aged patients, minimal inclusion of older patients. So they want patients who only have minimal comorbidities, and it's cancer center-based, and there is little community involvement in these patients. And if you look at, compared to breast cancer or any other cancer, there is much less articles written on or literature on patients who are aging. And there is essentially no data for patients who are greater than 80 years of age. We extrapolate the data from younger patients, and we want to do everything that needs to be done. So essentially, there are fewer trials available. We need to introduce better trials for us to take care of these patients. And that's pretty much it. Thank you. And hopefully, I have all these patients who will come similar to this. Thank you.